Good afternoon. I am Stina Klemming, neonatologist and NIDCAP trainer at the Lund-Malmö NIDCAP Center in Sweden. I have been working at the Astrid Lindgren's Children's Hospital, Karolinska University Hospital, Sweden for 22 years and got all my training there. We will now talk about immediate skin-to-skin contact and mother-newborn couplet care as a way to keep mothers and newborns always together in zero separation. Or, as the title in your program at the do's and don'ts, skin-to-skin contact in the delivery room and beyond. We will go through the updated recommendations for immediate skin-to-skin contact, touch on the evidence, including our results from the immediate parent-infant skin-to-skin study, IPISTOS, and from our experience, I will present requirements for clinical practice and safety for immediate skin-to-skin contact for very preterm infants. I will also mention a little bit about how continuous skin-to-skin contact is facilitated by keeping mothers and babies together within the concept of care called mother-newborn couplet care. I have consent for all pictures and films. I am a member of and a NIDCAP trainer in the non-profit organization NIDCAP Federation International. Being close and in skin-to-skin contact is instinctively right for all parents and newborns directly at birth. Biologically expected experiences during the early sensitive periods of the first minutes, hours and days of life should be presented for all newborns and their parents. Immediate mother-infant skin-to-skin contact, smelling, connecting, suckling and getting breast milk by mouth. Skin-to-skin contact also means important processes of stress regulation with lowered cortisol, sensory stimulation with increase in oxytocin, nutrition through instinctive behaviors, microbiome maturation and immune competence, adaptation and stabilization of physiological systems, and probably important epigenetic programming, and many other regulatory processes. As a cornerstone of the concept infant and family-centered developmental care, all newborns and mothers should be together directly from birth and onwards. Most things for most babies can be done without separating baby and mother. Here, nasal CPAP therapy and peripheral line insertion in a baby boy born in week 31, and so far, during the early sensitive period of his first 1000 seconds, he is together with his mother. Zero separation is a vision for all newborns. Sometimes we need to separate the baby and the mother for life-saving interventions that were not planned for or prepared for. And sometimes we can't do perfect, but we can always do something. And our mission is to take thoughtful preparations and plans for zero separation in as many situations as possible. In our Swedish experience, the change of systems towards early skin-to-skin contact and zero separation started with education in infant and family-centered developmental care, IFCDC. In Sweden, this has been training according to the NIDCAP, the Newborn Individualized Developmental Care and Assessment Program. With champions in IFCDC, NIDCAP professionals trained in observing infant behaviors and needs, and in supporting and collaborating with families, we see a change in mindset, a change in culture and in systems for a nurturing care and environment for infants and mothers and the rest of the family. This register study on data from the Swedish Neonatal Quality Register from 2020 to 2021 by my colleagues Agnes Linnér and Siri Liljesköld showed that a minority of extremely and very preterm infants were exposed to skin-to-skin contact on the first postnatal day. Daily duration during the first week of life amounted to less than 2 hours per day. Initiation time and daily duration varied among gestational ages and between different regions of Sweden, but as a mean, we did not live up to the current recommendations for early initiation and prolonged daily skin-to-skin contact in the NICU. The World Health Organization, WHO, announced updated recommendations for the care of the preterm and low birth weight infant in November 22, and the even stronger position paper and implementation strategy for scale-up of KMC in May last year. It states that all infants above gestational week 27 and 1000 grams should have skin-to-skin contact as soon as possible and continuously for as much as possible with a minimum of 8 hours per day. Some 50 years of research concludes strong evidence that skin-to-skin contact initiated immediately at birth and prolonged during neonatal care and at home has positive effects on breastfeeding, cardiopulmonary stability, thermoregulation, mortality, infection rates, well-being, stress regulation, buffering of stressful events and pain mitigation, growth and weight gain, and neurodevelopment, as well as strengthening parent-infant bonding, parental responsiveness and sensitivity, and parental mental health. There are many strong reasons to find new ways of working to implement these strategies of zero separation for better well-being and better outcomes for all babies and all families in all different settings. With this statement, the WHO also envisioned for the healthcare services to be reorganized around the mother-newborn dyad and the family as an inseparable center in zero separation. This review of skin-to-skin contact initiated before 1 hour after birth offers practical guidelines. The author and expert group of this publication highlights the considerations, ethics and risks of not offering immediate, continuous and uninterrupted skin-to-skin contact, and especially in the context of the Convention of the Rights of the Child. Recently, the Canadian Pediatric Society published a position statement on skin-to-skin contact, stating that benefits outweigh the risks in most situations, and that despite challenges, providers in low, middle and high-income countries should implement procedures and accommodations to ensure immediate and prolonged and even continuous skin-to-skin contact as a global standard of care for both term and preterm infants and their families. The very large IKMC study run by the WHO has been transformative in our knowledge for immediate skin-to-skin contact for preterm and low birth weight infants. It is an international multi-center RCT on over 3,000 preterm infants with birth weight 1,000 to 1,800 grams. It was run in low and middle income settings in India, Malawi, Ghana, Nigeria and Tanzania. To be able to do this intervention, the unit also had to implement mother-newborn couplet care, where mothers and newborns are cared for together, also when in need of specialized care. This intervention resulted in a 25% reduction in neonatal mortality, with the primary driver being lower rates of invasive infections. Here you see Nils Bergman, Björn Westrup, Stina Rettedal and Agnes Linnér, who were all very important in the IKMC trial and in the EPISTOS study. And here we see the EPISTOS team, the immediate parent-infant skin-to-skin study at Karolinska, Sweden and at Stavanger, Norway. The clinical trial was conducted when I was still working at Karolinska, and the clinical work there was done by Agnes Linnér, Siri Liljesköld and myself. We randomized 91 very preterm infants before birth to either immediate skin-to-skin contact with the parent or conventional care in an incubator for the first 6 hours after birth. We will now for 3 minutes listen to one parental experience from this study.
A small child needs its parents. A tiny child needs them even more. And if a parent's love and closeness aren't paramount in a child's well-being, then what is?
The perfect and tiny little boy, and was immediately placed on mom's chest. There were machines and hands everywhere, and although neither of us could really see him, it was comforting to know that one of us could actually feel him.
I could feel him. I could follow the nurses' faces and facial expressions as if they were me they were working on. A strange calm settled in.
For 7 hours, Benjamin lay uninterrupted on his mother. All the necessary tests were performed and checks were carried out where he lay. It felt incredibly natural to have him on his mom's chest. We have promised our boy eternal love and security. We have promised him never to let go of his hand.
Without a word, we divided the day into 8-hour shifts, day and night, that our boy should have us all the time, as he knows nothing about the world. We must help him. We are the adults, and he is the child. The benefit for Benjamin was the most important for both of us. Zero separation facilitated the healing of our wounds, open wounds that we had carried with us into this pregnancy, but also all the wounds that had arisen during the pregnancy with Benjamin, not daring to really be happy either, because life is so fragile. The feeling of having failed the pregnancy is overshadowed by the feeling of being able to care for your child.
Being someone's most important person for real and from the first second is comforting. Not having to leave him had a greater effect, and we dare to believe that we did everything in our power to give him the absolute best. Makes us today look back in our period at the NICU with warmth, gratitude, and some joy.
We are sure that the feeling of holding Benjamin skin to skin helped us to find inner peace. Being able to care for your child skin to skin when there is a medical possibility feels like such an obvious thing. We are so grateful for the opportunity to take care of our son from the very beginning.
So, this way of working is supportive for families and asked for by parents. It also shows important scientific improvement compared to traditional care in separation. In this publication of the primary outcome, we reported that the 46 very preterm infants who were randomized to immediate skin-to-skin contact, here the red line, stabilized their cardiorespiratory system better and faster during the first 6 hours of life than the 45 infants that were cared for in an incubator, the blue line. This was according to the Scrip score with heart rate, respiratory pattern, and need for respiratory support. A finding that showed that the improvement in Scrip score was clinically relevant, with actual improvement in clinical stability, was that the skin-to-skin group needed central lines significantly less often than conventional care infants, with 6.5% compared to 22%. The need for lines for a baby above 27 weeks in our setting is evaluated during the first hours after birth, and the infants in the skin-to-skin group were at that time stable and assessed not being in need of this intervention. When minimizing invasive and stressful procedures like putting in central lines, doing x-rays, etc., the effect of skin-to-skin contact is believed to be further increased. A secondary outcome on thermoregulation concluded that both groups had normal temperature and that skin-to-skin seemed to protect against hyperthermia from a heater. Again, the intervention group in skin-to-skin is in red. This publication concluded that parents felt that skin-to-skin enhanced connectedness and bonding and was empowering for parents. It was also concluded that mothers desired to be with their baby from the birth and onwards, and that there was a need for mother-newborn couplet care. Cyril Lillicheld also recently published the first follow-up data showing that at 4 months corrected age, infants cared for in skin-to-skin contact the first 6 hours developed higher social competences according to the PISERA, the Parent-Child Relational Assessment. The PISERA was scored from interaction with the mother at 4 months corrected age. However, interesting enough, most of the infants spent most of the initial skin-to-skin time with the father. More publications will follow from Epistos, for example on breastfeeding, epigenetics, and the 2-year follow-up data. We conclude that immediate skin-to-skin contact is feasible and should be the desirable standard of care for very preterm infants. We will now go through the clinical practice from the Pistos and some other experiences from Sweden. Stabilization and newborn care in zero separation need to be planned well, but is really not different from our regular care. The care is the same, the place is different. We need mobile equipment and NICU staff to be in the delivery room. We need the equipment to be connected to gases and power supply. Respiratory support and monitoring, as well as temperature control, tubes, lines, feedings and fluids are planned as usual, only the place is different. We need to inform and support parents to keep a calm atmosphere and to take photos. The most important thing for newborn care in the delivery room are good planning, clear leadership and communication for safe and optimal care, so things are pretty much the same. We need to go mobile. With mobile skin-to-skin compatible equipment with everything we need mounted, respiratory support of choice, gas bottles, humidifier, battery monitoring devices, APGAR clock, nursing gear and other equipment for the care of the newborn. We also need an adult bed for the mother, a wheelchair for the other parent and maybe a stabilization platform or trolley. Stabilization trolleys were invented for stabilization and resuscitation on intact umbilical cord. This equipment also adds a welcome backup plan for the place of care. This makes the team feel safe and so that they dare to try new ways of working. It is a way to increase safety for our patients in all situations. And here we see how this can be used as a mobile equipment device when caring for a newborn in immediate skin-to-skin contact. Elwin was born with a cesarean in week 28 plus 2, weighing 1,052 grams. He was put in immediate skin-to-skin with the surrogate, the sister of the mother, and got all the conventional care with nasal CPAP monitoring and temperature control. The place was different, the care was the same. You see how we put the electrodes on the back since the infant is in either a tucked prone position or inside lying. We put the pulse oximeter sensor on the right hand and we cover the baby with a merino wool blanket as soon as possible. The first patients we stabilized in immediate skin-to-skin contact were covered with a plastic wrap, but we found out that merino wool was better. We hold the nasal CPAP, let the infant adapt as undisturbed as possible for a while, and we assess breathing movements. I asked the aunt if she felt the boy breathing, and yes, she did. She felt that he was breathing well. We put an elastic band on the cord instead of the hemostatic forceps, and you can cut it long and make it shorter later. Makes it easier. We give vitamin K, and at the same time we do a quick assessment of genitals and anus, not to get any surprises later on. There is no stress. When the situation feels stable and calm and the baby is breathing well, here at 8 minutes of age, we put the cap for the CPAP on, we keep the wool cape over smooth along the infant's body, and over that comes the KMC binder. Over this we put a heat-preserving blanket. At about 30 minutes of age, Elvin received a nasogastric tube and a peripheral line, still in skin-to-skin contact. The exact procedure can of course differ slightly between different patients and settings. Immediate skin-to-skin is possible also for twin birth. After the cord was cut, twin 1 was put skin-to-skin with the father and received care with nasal CPAP monitoring and eventually also nasogastric tube and peripheral line. Twin 2 stayed with the mother and received care there. Care was the same, the place was different. As we see here, we had double sets of mobile equipment and initially we had 2 neonatal nurses. One nurse stayed with the family in the delivery room for 2 hours. 45 minutes after delivery, the mother started to hand express milk, while twin 2 was still in skin-to-skin with the mother. She expressed for 30 minutes, and the amazing amount of 20 milliliters of colostrum could be shared by her twin boys. Safety precautions for the mother and the newborn are essential. As always, we need a backup plan and continuous communication in the NICU team and with the obstetric and anesthetic teams. Here the mother was bleeding heavily, so the infant was moved to the father for evaluation and care of the mother. The father was already prepared that this could happen, could be needed. He was already dressed with a KMC binder, and we had a wheelchair for the father in the birth room. Same goes for preparations for the risk that stabilization is not possible in skin to skin. This girl was put immediately skin to skin with her father after a C-section in week 30+1. She did not breathe, got a few puffs with the T-piece, seen to the left, and was then moved to the prepared open incubator for stabilization, to the right, after which she could safely be put skin to skin with her father again, the little picture in the middle. At this time in 2018, there were no stabilization platform devices available, so we used an open incubator or a resuscitator as a backup place. And this boy from the pilot study for Epistos was born vaginally at 29 weeks. He was in need of full stabilization, including intubation and surfactant administration. At 1.5 minutes of age, he was put on the resuscitation table in another room, was stabilized and at 30 minutes of age, he could be put back in skin to skin, and this time with his father, and brought back into the birth room and the mother. Little Liv here was born in week 28 and 4 days, weighing 965 grams. She was initially on an open incubator because the team was not fully prepared, since this was an urgent C-section, because of a severe preeclampsia, and Liv was expected to be very small. She was put in skin to skin with her father at 8 minutes of age. The family was reunited like this when the mother was still on the operating table and Liv was 15 minutes old. If we stay in the delivery room until the mother can be moved, we can transfer the mother and the baby to the NICU together, using a bed for the mother, as seen in the pictures below. When this is not possible, we facilitate connection between the newborn and the mother through a period of skin-to-skin contact, holding, touching, smelling, and then we transfer the baby with the father, the other parent, or a surrogate, like Elvin and his aunt, and Liv and her father. The mother comes when stable enough, according to local guidelines. This is Nils Bergman in Nigeria during the IKMC trial. For safe, immediate, and continuous skin-to-skin contact, we recommend a KMC binder of some sort, as seen here, to secure the airway and prevent obstructive apneas, and for parents in the NICU to do continuous skin-to-skin day and night, also when sleeping themselves. This is a newborn in unsafe skin-to-skin contact, suffering a sudden unexpected postnatal collapse. This can and need to be prevented with observation and monitoring, as well as support for a safe and comfortable position, as seen here, from a C-section with immediate skin-to-skin contact in a binder specially designed for C-sections. And here at the maternity ward with late preterm twins in intermittent skin-to-skin contact in a special binder and shirt. And in the neonatal unit with continuous skin-to-skin contact and safe co-sleeping with binder and monitoring. So safe skin-to-skin contact includes sensitive and optimal medical and nursing care with temperature and glycemic control, adequate respiratory support, secure airway in a sniffing position and at a kissing distance for the parent, high up sternum to sternum. Postural support around the infant from the sides and inside a binder, so that the infant gets support for a prone, tucked fetal position with the head only carefully to the side, with shoulders rotated inwards and a curved back, since this avoids maximum rotation of the head, or for a supported side-lying position. The same goes for skin-to-skin contact after C-section. It is important that the position is both safe and comfortable for the infant and for the parent, since we want to support prolonged skin-to-skin contact. For this to be possible, we also need the system to support this with mother-newborn couplet care, which is a concept of care where care for a sick or preterm newborn is provided in close proximity to and coupled with the care for the mother. The couplet care is defined as the time from when the mother gives birth to the baby until the mother is discharged. After discharge, the mother as well as the other parent and family members should be able to continue to stay with the baby in the hospital until discharge of the baby. But we only call the care couplet care when we have two patients in need of hospital care, and their care is coupled for them to be together. So couplet care is a way to keep mothers and newborns together during the first hours and days when the mother is still a patient in the hospital. For this, we need a flexible system, and we need to reimagine how care is organized. This mother was moved from the operating room and directly to the birth room she was in before the decision of an urgent C-section. She still has her spinal anesthetic, and the anesthetic nurse comes along for a handover to the obstetrical team for safe care of the mother. The neonatal team follows to care for the moderately sick newborn in need of respiratory support with CPAP. This routine, to skip the postoperative ward and delegate the task of observation of the mother from the anesthetic team to the obstetric team, is practiced in several units in Sweden and has been supportive for non-separation. This is the same mother-newborn diet. The mother is treated for a sepsis, has 2 peripheral lines, IV fluid and antibiotics. She has frequent monitoring of physiological parameters. She still has a spinal anesthesia. The baby is 30 minutes old, has respiratory support with CPAP, and has been in skin-to-skin contact with his mother from birth. We see the obstetric, anesthetic, and neonatal teams working together. The grandmother was with the mother during the C-section and as a surrogate and companion instead of a partner. 45 minutes after birth, also the grandfather arrived to congratulate his daughter and welcome his grandchild. Safe couplet care with a neonatal nurse for the sick newborn and a midwife for the mother, and true family-centered care in 3 generations. Here is another example of a flexible system reimagining how care is organized. The mother needed observation and treatment in the adult intensive care unit after a C-section. The diet was transferred there in skin-to-skin contact and is in continuous skin-to-skin contact during the treatment of the mother. Because of a tachypnea of the newborn, a neonatal nurse followed to observe the infant and brought equipment seen to the left for intensified care of the infant if needed. Here are 2 different ways in organizing nursing care to keep the diet together. To the left you see a midwife who is also a NICU nurse, checking on her 2 patients in the neonatal unit, a preterm infant and the mother, delivered with a C-section because of diabetes and preeclampsia. In the picture to the right we recognize the term baby and the mother in the perinatal department Capio St. Göran. The neonatal nurse looks after the boy and the midwife cares for the mother. So instead of having 1 super nurse, we have 2 or even 3 nursing teams working together, delegating tasks between them. With immediate skin-to-skin contact and mother-newborn couplet care for separation, we see a new parental behavior with increased participation in care as well as prolonged and even continuous skin-to-skin contact day and night. Full closeness in continuous skin-to-skin contact is possible for at least some families, like Benjamin and his parents. Let us increase the number of families that, instead of the devastating experiences of separation and disconnection, get an experience of separation and connectedness from the birth of the baby and onwards. My contributors of knowledge, inspiration and support for this talk and the work I've been part of are the NIDCAP Federation International, the Pistos team, the group for IVCDC in the Swedish Neonatal Society, the Lund Malmö NIDCAP team, the Capio St. Göran department, and all the families. I would also like to mention the organization for the Swedish Conference on Ultra Early Intervention and the YouTube channel NIDCAP Sweden. with open access to all the recorded conferences since 2015 and a special playlist of video presentations on our work from Epistos. Thank you for your attention and good luck with your new ways of working. And there you have my email address if you would like to contact me, and the QR code for the YouTube channel.